We're going to start with Richard Barth, who has been on a couple of panels already today, I think maybe all of them. From Dartmouth Medical School, so please.
Okay, well, thanks again for letting us share some of this data. I feel pretty humbled by this because we ended up just kind of coming up with some guidelines without actually really thinking about it very much. And obviously, you guys are going to be putting all the thought into making the guidelines now. But I can share with what we did, and then I'm happy to share in its sort of shortcomings or whatever. But anyway. I started getting interested in this in late 2015, basically in response to so many young people dying of opioid overdose in New Hampshire, and said, well, as a surgeon, I prescribe a lot of opioids. Hopefully I can, I have to do something about this. And so I did a literature review then, and really there were no studies that were looking at best prescribing practices in general surgery at the time. There were a handful of studies there in some plastic surgery and urology, but really nothing for general surgery. So we started looking at sort of the 5 common outpatient procedures that were performed at our institution: partial mastectomy with sentinel node biopsy, lap choles, lap hernia repairs, open inguinal hernia repairs, and basically just looked at the prescription data, opioid refill data. We excluded patients that had recent opioid use or history of opioid abuse, and then basically just called patients and asked them how many opioids they took. So this table shows, is on the top, is the 5 different operations: partial mastectomy, sentinel node, lap chole, lap inguinal hernia, and then the percentage of patients receiving opioid prescriptions, you can see, is just about everybody was getting an opioid prescription for these outpatient operations. And the median number of pills was 20 for the breast surgeries and 30 for the others. You can see it was a remarkable range of opioids that were being prescribed. So anywhere from 0 to 60 for a partial mastectomy sentinel node, 15 to 120 for inguinal hernia repairs. So obviously we really didn't know what we were doing in terms of how many to prescribe. So then we just looked at how many were prescribed and how many were taken. So this top curve on the y-axis shows the percent of the total population that was getting a certain number of pills, and on the x-axis is number of pills. So for 175 patients that had a partial mastectomy, the median number prescribed was 20. The range was 0 to 50. And then here's the number that were taken. So 75% of the patients weren't taking any opioids, we have similar data for lap choles, where, again, the median number prescribed was 30 with a range of 0 to 100, and then the number taken was much less. And open inguinal hernia repair, very similar kind of pictures. So overall, just to summarize that, about a quarter of the pills were taken. And since our publication, several other groups have described overprescribing, and really almost right around that 25% mark are being taken, both group from Michigan and from Mayo Clinic and from University of Vermont. So where to go from there? So we said, okay, this is the guideline part. Okay, so he said, all right, let's try to put together then recommendations on how many to take. So it's a quote in quotes, this ideal number of pills is try to say, okay, what's a reasonable number then? And we said, well, let's just take care of the opioid use of at least 80% of the patients. So this is for the lap chole data. I put a little red box around over 80% of the patients. So if we gave them 15 pills, we'd take care of over 80% of the patients' opioid needs. And so on the bottom then, if you see the median number of pills actually prescribed for those different operations, it was 20, 20, 30, 30, 30. And then the ideal number of pills based on satisfying 80% of the usage would have been 5 for partial mastectomy, 10 for partial mastectomy sentinel node, and 15 for the lap chole, lap inguinal hernia, and inguinal hernia repair operations. And if we did that, actually, and prescribed the ideal number, then it would be a 57% decrease in the number of opioids that were prescribed. So I went to my general surgery section meeting, and I told everybody about this data. I sent emails to everyone. We had teaching sessions with the residents, and then basically I just observed what happened. I didn't say anything else. We also did recommend that during these sessions that providers use acetaminophen and ibuprofen first and then opioids, and recommend that to their patients. So we basically observed the same 5 operations, same surgeons, and collected data on opioid prescribing and use in these patients. And so what this table shows is a dramatic decrease in the prescribing after just this provider education. So the operations are on the left there, and you can see both the mean number of pills dramatically decreased for all 5 operations, the median number dramatically decreased, and the range was much tighter. So instead of 15 to 120 for inguinal hernia repairs, now it was between 0 and 40. And then so that was about over 50% decrease in number of opioid pills actually prescribed during those time periods. So you might say, well, boy, what happened to the patients? You only prescribed enough opioids for 80% of them. What about the 20% you didn't give enough opioids to necessarily? Well, of those 224 patients, only 1 patient required an opioid refill. So, I sort of warned the nurses in my clinic that a lot of people might be calling for opioid refills, but really that didn't happen. So we still did take care of their pain. And in fact, we were still overprescribing. So because only 34% of the prescribed opioids were actually taken by the patients. So it was clear from our study and others. There's a nice paper from Michigan that also has recently shown this, is that the number prescribed has a direct association with the number actually used. And so we showed that in 4 of these 5 operations, that was the case. So not when we prescribed less, much fewer opioids were used. Well, then we sort of turned our attention to the inpatients, so patients who were discharged after surgery that required inpatient admission. And in the 6 New England states, there are laws that limit the number of pills prescribed to a, quote, 7-day supply. And as was mentioned earlier by Dr. Delgado, there's a lot of ambiguity there. So is a 7-day supply 21 pills or 84 pills? Do you assume patients are going to use less pills every day? Is 7 days the right number, or is it 5, or is it 10? Really no one really knows, but yet there are these laws there about this. And so we thought, well, let's try to quantitate this a little bit better, and looked at some common inpatient operations that we did. So operations on the stomach, liver, pancreas, colon, abdominal wall hernias, studied over 300 patients. And again, most of these went home with opioid prescriptions when they were discharged. So what we're looking at is what's the right number of pills to prescribe when they go home after this inpatient admission. So we feel that with this study, we got 90% of our patients to answer the questionnaire or a phone call. So we really got, I thought, pretty good follow-up on these patients and how much they actually used. We had 2 analysis groups, patients who were discharged on post-op day 1, and then others that were discharged on post-operative day 2 or later. For the ones in post-op day 1, we just looked at their home opioid use, and for people who discharged on post-op day 2, and this is something I referred to a little bit in my presentation earlier, we looked at the inpatient use on the day prior to discharge, and then we looked at their home opioid use. And so here's just the data for people discharged on post-op day 1. This included patients that had some laparoscopic procedures on their stomach, some other operations just required a night in the hospital. Well, if we looked at this group, 85% of the patients' opioid needs would be satisfied if you had prescribed 15 pills, just looking at this use curve. And then when we looked at the patients who were discharged on post-op day 2 or later, we did univariate and multivariate analysis of the factors associated with home opioid use, and the most important points were that the number of pills taken the day prior to discharge was the best predictor of how many opioids were used at home. And in fact, it was independent of the operation performed, so this was not a procedure-specific thing then. It was really that the better way to look at this for inpatients was how many took the day before they were discharged. Again, it takes into account, I think, a lot of other aspects with regard to pain tolerance, with regard to other patient factors, that we've talked about at this meeting already that might be very difficult to actually quantitate, but it's very simple to just go and see how many pain pills they took the day before they were discharged and use that as part of a guideline. So here's the data. If patients took no opioid pills the day prior to discharge, then 85% didn't use any at home. If they took 1 to 3 pills, 85% would be of their patients would be satisfied with if you gave them 15 pills for as a prescription, and if they took 4 or more, if you prescribed 30, that would satisfy 85% of the patients. So that led us to then this very simple guideline then to satisfy 85% of the patient's home opioid usage. If the discharge on post-op day 1, just prescribe 15. If they were, they didn't use any, prescribed none, 1 to 3 pills, 15, and greater than 4 pills, it was 30. So, and this isn't insubstantial because about 40% of our patients didn't use any the day before they were discharged home. So, so there's a large number of patients then who would routinely be prescribed opioids who you really don't need to prescribe opioids to. But you might say, well, what about the outliers? You're only taking care of 85% of the patients. So we called these patients and said, hey, you asked them again what they were taking their pills for, and only about half were taking their opioids for surgical pain associated with their procedure. So many were taking it just to go to sleep. Some were taking it just because they were prescribed a certain number of pills, and you basically better take all the pills that your doctor prescribed for you. So that's why they were taking them. So I'm not so worried about, only sort of prescribing enough for 85%, because I think that this is going to take care of the postoperative pain needs for well over 90%. And the other small percent, as we discussed earlier, I think you can e-prescribe for those and not have patients suffering when applying a guideline like this. So again, our potential savings then, if our guidelines were used, was about a 40% decrease in opioids prescribed. So there's, you're very familiar with prescribing recommendations then, that are out there now. This is the group from Michigan has put together these guidelines. There's a recent paper from Hopkins describing additional guidelines and guidelines from the Mayo Clinic as well. So there are lots of potential guidelines out there now, and I'm happy to answer any questions or have our guideline creation critiqued as you see fit.